Hello, everyone. Welcome to IAPD20, the first virtual event of IAPD. So I'd like to ask how you are doing very well. Due to COVID-19 pandemic infections, actually IAPD Global Summit has been postponed, unfortunately. So IAPD Board of Directors decided to prepare this wonderful online congress for all the oral health professionals who are very interested in pediatric dentistry. Let me introduce myself. My name is Young Jae Kim, one of the board of directors at IPD, and also a moderator of this session. And hopefully you enjoy this congress, especially the very first session now. Let me introduce the speaker, Kitae Park. He is a professor at Samsung Medical Center at Sungkyunkwan University, and he was the chair of scientific committee at IPD 2013. You guys remember? Hopefully, which was really great. And actually, he has a double board. He studied pediatric dentistry at New York University, United States, and then got trained as a dentist as well at Northwestern University. So he's a pediatric dentist as well as an orthodontist. Actually, he's a very renowned speaker, especially about the early orthodontic treatments for pediatric patients. Today, he's gonna talk about essential orthodontic concepts. So if you have any question, you can use the Q&A button on the bottom of your Zoom screen, or you can use the Q&A session Q&A on the right side, even after the lecture. So I believe Kitae Park will answer the question afterwards. Okay, let's get started. Professor Park, would you please?
Okay, thank you very much for your introduction. Hello everyone, hello doctors somewhere in the world. I'm Kitae Park from Korea. This is my great honor to speak for IAPD Virtual for the first time, and it's even greater honor to be the first speaker. I appreciate a lot to the members of IAPD for preparing this honorable session. I'm from Seoul. Seoul is very exciting city, so someday very soon I hope you can travel to Seoul or you can travel to anywhere. I'm working at Samsung Medical Center, which is in Seoul. It is one of the big 5 hospitals in Korea. It is affiliated to Sungkyunkwan University Medical School. And this Samsung is the same company which is well known for Galaxy smartphone. Okay, let's go to today's topic. My presentation today is mainly about the general overview, not about the special techniques. As a pediatric dentist, we do a lot of restorative dentistry and preventive work, but you may not do orthodontic treatment. It will be your choice. But as a pediatric dentist, we are dealing with changing skeleton and changing teeth, so it is very important to have good orthodontic knowledge. In orthodontic treatment, we face so many techniques and new materials, so we tend to concentrate what technique we should use or what appliance we should use, but in reality, not any one technique is far superior to other ones. In order to manage orthodontic problem of our children, we don't really need sophisticated technique, we just need good understanding of their problem. In orthodontic treatment, we should have different strategy for adult and children. For adult, we are dealing with fully grown facial skeleton, so we cannot really control the bones. So we just concentrate how to move teeth. So for this kind of treatment, there's no proper timing. It can be any time. But for children, we are dealing with changing skeleton and changing teeth. So it is much more complex, especially when we decide proper treatment timing. I like showing these slides for explaining good concept in early orthodontic treatment. In orthodontic procedures, there are two types. One is orthopedic treatment, the other one is orthodontic treatment. Orthopedic treatment is to correct skeletal discrepancy by controlling the growth of mandible or growth of maxilla. So for this type of treatment, it can be done at some time before growth is completed. But the other orthodontic treatment is moving teeth in the bone. So this type of treatment, it can be done at any time, even after growth is completed. So simply speaking, if you find your patient's orthopedic problems, it will be a good guide for deciding proper treatment timing. Then, how do we find patients' orthopedic problems? When a patient first comes into my office, the first thing I do is facial evaluation, because this facial profile can tell us very clearly if patient has any skeletal discrepancy. For example, we may see convex profile, we may see concave profile, we may see straight profile. With these two profiles, we easily know they are class 2 or class 3 malocclusion. That is orthopedic problem. So we know they need orthopedic treatment at some time before growth is completed. But if we see our patient profile straight, it is usually orthodontic problem, so it just requires orthodontic treatment at any time, but I usually recommend treatment timing near adult stage. So for proper treatment timing, you always check if there is any orthopedic problems. If yes, you can consider early stage treatment. If you don't find any orthopedic problems, you can consider treatment at the later stage. Okay, let's go to each malocclusion from this convex profile, class 2 malocclusion. For class 2 treatment, traditionally, there were two modes of treatment. One is two-phase early treatment. The other one is one-phase treatment. In two-phase treatment, usually in early mixed dentition stage, we start phase 1 orthopedic treatment for a year or year and a half, and then we have resting period. And at patient's growth peak or even later, we usually start phase 2 orthodontic treatment for final finish. So I'll show you one example of two-phase treatment. He was 9 years, 10-month-old boy. His cheek complaint was flared upper teeth. This is his initial picture. We can see his profile is very convex. He has increased 9 mm overjet and 70% overbite. And he was in early mixed dentition stage. I usually use hand-wrist X-ray to evaluate patient's growth stage. So from here, I can see his growth stage is way before pivotal growth spurt. And today I will not mention a lot of numbers from cephalometrics, but from here I can see he has skeletal class 2 characteristics. So for the first phase 1 treatment, I used some kind of orthopedic appliances. So I achieved orthopedic correction from the appliance and also from natural growth of mandible. So this is phase 1 final picture. Profile is improved. Now he has much better class 1 occlusion and overbite and overjet is improved. He is still middle mixed dentition stage and his growth is still before pubertal growth spurt. And this is before and after cephalometric x-rays. We can see some change, molar relation and overbite overjet. And this is 6 years after phase 1 treatment. Now he still has pretty good straight profile, a little convex, but it's not really bad. And he has pretty good class 1 occlusion, even if he had some minor crowding here. So I added question mark here because we can provide phase 2 final orthodontic treatment at this point. But if this patient doesn't want any more treatment, it is still okay. So I add question marks here. Now he is very close to adult stage. And this is his positive cephalometric changes. So from here, I can explain for 2-phase treatment, we usually start phase 1 treatment in early mixed dentition stage. And for phase 2, we can start it from patient growth peak or even later. But in early 90s, there were 3 major randomized clinical trials of early 2-stage versus 1-stage class 2 treatment. The conclusion was this. If you use headgear or functional appliances for phase 1, you will have pretty good result at the end of phase 1. But at the real final stage, you will not see a lot of change, a lot of differences between phase 1 treatment or 1-phase treatment. So nowadays, evidence is very important for treatment. So best time to treat most class 2 cases will be 1-phase treatment at patient's growth peak. So I show you one example of 1-phase treatment. He was 12 years, 6 months old boy. His chief complaint was, my front teeth are sticking out. And this is his initial picture. We can see he has convex profile, 8 mm increased overjet, and some crowding. And he is in permanent dentition stage. And his growth was getting very close to his growth peak. And from cephalometrics, we can see he has class 2 skeletal characteristics. And these are the appliances I used for orthopedic treatment. So for the first stage of this 1-phase treatment, I achieved orthopedic correction through orthopedic appliances and also from natural growth of mandible. So this is in 14-month picture. So from here, I can see his profile is already improved and he has already pretty good class 1 occlusion. And this is in 14 months cephalometric changes. You can see pretty good change. And this is his final picture. Now he has very good straight profile, and very good class 1, nicely aligned occlusion. So this is before and after cephalometric X-ray. And these are before and after hand wrist X-ray. From here, I can see his treatment was very well done using his growth peak. So this is one-phase treatment. So again, by evidence, best time to treat most class 2 cases will be one-phase treatment at patient's growth peak. So this is the mainstream for class 2 treatment, and there was even more critical comment for two-phase early treatment. Don't waste your time and money on two-phase early treatment. One of the most distinguished professors in orthodontics, Dr. Profit, described early treatment for most class 2 children is no more effective and considerably less efficient than later one-stage treatment during adolescence. But he also described class 2 clinical trial results, this means previous researches, do not mean early class 2 treatment is never indicated. So in some cases, we still need early treatment. So I think there should be good guidelines in order to select good indication for phase 1. So I think simply, I think class 2 case should be very severe. Then we can consider early treatment. So first, patient should have very convex profile and at the same time, very excessive overjet, and at the same time, full step class 2 molar relation. So if patient meet these criteria, you can consider early two-phase treatment. So I think this patient is good example for two-phase early treatment. He has a very convex profile, increased overjet, and he was early to middle mixed dentition stage. And from this picture, you can see better. He has very convex profile, a very excessive overjet, more than 7 millimeter, and full step class 2 molar relation. But so this patient is good indication for phase 1. But at this point, I check one more consideration, that is patient's psychosocial aspect, patient's desire. So if he really wants to fix his teeth, then we can help him immediately. Then we can start two-phase early treatment. But if he doesn't really care and if he doesn't want early treatment, we can wait until proper time. That means we can wait class 2 treatment until his growth peak. So this is a kind of flow chart for class 2 early treatment. So if the patient meets these criteria, then we can consider early treatment. But at this point, I told you we check one more thing, that is patient's desire. If he really wants to fix his teeth, then we can start to phase early treatment. If he doesn't want, it's still okay. We can wait until one phase treatment timing. So this is a kind of a flow chart. Let's see one more case with these guidelines in mind. She was 8 years, 10-month-old girl. She complained was, my teeth are proclined. From here we can see her convex profile and 7 millimeter overjet. And from here we can see her molar relation is not really full step class 2, it is just end-on class 2 molar. This means this case is not that severe for phase 1 early treatment. So by these guidelines, she is not a good candidate for two-phase treatment. So she usually need one-phase treatment. But at this point again, I check patient's desire. If she really wants to fix her teeth right now, then we can provide two-phase early treatment. So this is the kind of general overview when you consider early treatment for class 2 malocclusion. Okay, let's go to concave profile class 3 malocclusion. Okay, we often see anterior crossbite, and then it is very important to differentiate if this is skeletal problem or dental problem, because treatment will be different depending on if it is skeletal or dental. So to differentiate if this is skeletal or dental, to me, the main key is again facial profile. With this anterior crossbite, with this facial concavity, I think it is real skeletal class 3. And if this patient has good profile, then I think it is dental problem. So for this patient, I provide orthopedic treatment, for example, face mask. And for this patient, I provide orthodontic treatment, for example, removable appliance. And for this patient, I improve his profile. And for this patient, I maintain her good profile. Of course, I double check with cephalometric numbers. I did a study which was published in Angle Society. I did a study about cephalometric characteristics of class 3 children and normal children in the primary dentition. So the result was I can see significant differences even in primary dentition in these skeletal numbers, for example, A and B or width appraisal, and also even in primary dentition, I can see dental compensation. So there are some differences in IMPA and upper 1-2 NA for this kind cephalometric numbers. So we can double check with cephalometric numbers. In class 3 treatment, there are two types of appliances. One is face mask and the other one is functional appliance. I personally prefer this face mask because this face mask is much better to improve concave profile by advancing the maxilla. So by evidence, face mask is effective in long-term, in short-term basis, but no guarantee in long-term basis. I fully agree with this. And many of us, including me, if we see anterior crossbite and facial concavity like him, we usually use face mask, and initially we have pretty good result. But in some cases, this case is really ended up as real surgical case. Then sometimes we are frustrated because our treatment is failed. But my point is that this is not really the failure because even this treatment result was in my treatment scenario already. I explain why this is not failure later. And I think in class 3 treatment, there are two groups. In one group, they usually do only orthopedic treatment and then do growth monitoring But in the other group, they don't do early orthopedic treatment. They just do later surgical treatment. I think in Korea, this is about 80%, and this is about 20%. In this group, they say class 3 early orthopedic treatment is useless because later surgical treatment is necessary anyway. In some cases, they are correct, but I don't really fully agree with them because again, I consider psychological distress of our children patients. For example, this patient, he was about 8 years old, anterior crossbite and facial concavity. So if I don't correct his problem right now, then he will have this anterior crossbite and facial concavity through his elementary and middle and high school. It can be a lot of stress for him because I can fix this problem within a year with face mask treatment. So I think early orthopedic treatment is much better than do nothing. In class 3 treatment, there are good cases and poor cases. I show you good case first. He was 5 years old, anterior crossbite and facial concavity. And this is after face mask, anterior crossbite is well corrected and profile is much improved. Here we can see better. Profile is much better now. And this is 2 years retention. Here we can see his profile is well maintained. Here he still has pretty good occlusion. So this is his long-term follow-up at age 5 before face mask. After face mask, good change. In 2 years retention, and at age 12, just still pretty good retention. At age 14, still very good retention. So I'm very happy with this case. Let's see the poor case. Here we can see anterior crossbite and facial concavity. And this is after face mask. Anterior crossbite is well corrected and profile is much better now. But in 2 years retention, we can see there are some class 3 tendencies. For facial profile is still okay, but at age 15, now I can see she is really the surgical case. Very disappointing case. Of course, I showed you very severe case, but from here, we should understand our treatment result will be depending on patient's growth, not by our treatment methods. So that's why I explained, even in this case, this is not really the treatment failure. Even this case was in my treatment scenario. This is my treatment scenario. At age 5, at age 8, age 10, I provide face mask treatment. I usually do my face mask treatment before middle school because of compliance issue. And then I do growth monitoring until patient's growth is completed. And when patient's growth is completed, I check if this patient is good for compromised orthodontic treatment or if this patient really needs surgical correction. Actually, in this period, I can provide face mask treatment, but there are some limitations. Because when I protract maxilla, I need good intraoral appliance. I usually prefer Hyrex expander or bonded expander. I never use this kind of appliance which is using only 2 molars. Because when I do early orthopedic correction, I want to achieve good orthopedic correction like this. I don't really want this kind poor anchorage. So at age 5, I can easily use this kind bonded expander and face mask. So it is good time. But after this period, there will be the bad time to use face mask because there are first molars are coming in. So it is difficult to cover all these posterior teeth. So I wait until age 8, then I can have 2 fully erupted first molars, then I can use bonded expander again. So it is another good time. And then afterwards, I can see a lot of primary molars exfoliating. So it's again difficult to cover all these posterior teeth. So at age 10, I usually have fully erupted first premolars. Then I can use this kind Hyrex expander as an intraoral appliance. That's why I have at age 5, 8, or 10. This means I try 3 times. This means just a good time should be different for individual case. So this is kind of general flow for class 3 treatment. And for class 3 treatment, I usually, when I make a consult for our patients or patients' parents, I emphasize there should be 2 options. As the patient's growth is getting completed, option 1, if mandibular growth is limited and facial profile is acceptable, compromised orthodontic treatment will be necessary. Option 2, if mandibular growth is excessive and facial profile is too much concave, orthodontic surgical option should be considered. I always emphasize a lot for class 3 cases, at the end of growth, we should have these 2 different options. So this is the general overview for class 3 treatment. Okay, let's go to straight profile. If we see our patient's profile straight, it is usually orthodontic problem. It is dental crowding. But even here, we can see some orthopedic problems, which is transverse problem. In transverse problem, we should see 2 aspects. One is mandibular deviation, and the other one is airway. Let's see mandibular deviation first. If there is transverse discrepancy, we often see this kind unilateral posterior crossbite, then it can cause mandibular deviation. This mandibular deviation is better to be corrected as early as possible. Otherwise, it will be more difficult to correct it because patient's habitual bite is getting stronger, and sometimes it can cause facial asymmetry. Treatment is usually by upper expansion. So in primary dentition, I usually use removable appliances. Then I can easily correct this mandibular deviation. And this patient is about 8 years old, early mixed dentition, and I can see unilateral posterior crossbite here, and it can cause mandibular deviation. And for this patient, I used bonded expander, and after maxillary expansion, I achieved 3D good midline correction. So depending on the cases, you may use removable appliance, a bonded expander, or even the Hyrex will be the possible option. Another aspect is airway. If patient has airway problem, it can cause from this simple snoring to obstructive sleep apnea. Pediatric obstructive sleep apnea is a common chronic disorder with a dramatic impact on systemic health and development, even in adolescents. So it can be associated with many problems like depression, behavioral problems, and hyperactivity. And the most common cause is considered adenotonsillar hypertrophy. And in addition to that, maxillary or mandibular deficiency is known as another risk factor. So, American Academy of Pediatrics considers adenotonsillectomy to be first line of treatment, and there are increasing evidences that maxillary expansion therapy is an appropriate alternative treatment option. So, for example, let's see this patient. This patient has pretty straight profile for his age, and from here we can see he will have just minor crowding. So I think this patient doesn't need really early treatment. So in the past, I didn't really do anything for this patient, even though I can see some constricted upper arch because I can see lower posterior molars inclined lingually. This is like dental compensation. But for this patient, I didn't do anything in the past because individual has different arch form. It can be square, ovoid, V-shape, or constricted. So every individual has different arch form. And in the past, in orthodontics, this arch form is better to be maintained because the orthodontic stability is better. That was past concept. So if we see this patient has been my patient for a long time now. He is 21 years old. From the front, he's okay. He's pretty good smile. He didn't complain anything about his teeth and nice alignment. But from here, we can see his arch form is very constricted. So now I regret I should have expanded his upper arch because in the long run, he may have obstructive sleep apnea. Then it will be very difficult to expand his upper arch. So I think there should be paradigm shift in order to manage this constricted arch form. The proper treatment timing nowadays should be different compared to the past. Dr. McNamara described good intermolar distance, and if it's 36 to 39 millimeter, we can consider patient has good width of maxilla, but if it's less than 31 millimeter, it's constricted. That's what he described. But this millimetric measurement should be different in different races. So we should always check individual arch form. It can be square, ovoid, V-shape, or constrict. So we should always check patient's arch form. And also we should check a dental compensation because if there is transverse discrepancy, we can see upper molars are flared buccally and we can see lower molars inclined lingually. That is dental compensation. So let's see another example. She was 8 years, 10-month-old, pretty good profile, a little convex, but I think it is good for her age. So from here, we can see she will not have a lot of crowding problem. That will be just minor crowding. But from here, we can see posterior dental compensation. There was some constricted upper arch. So this is after expansion. From here, we can see better. I used upper Hyrex for expansion and a lower Schwartz expander. And this is after expansion. So for this kind early expansion treatment, I do a lot more than before. So for class 2 treatment, I think we should think differently for proper treatment timing, because this is typical arch form of class 2 division 1. They usually have V-shaped constricted upper arch. So if we consider patient's airway, the treatment time should be much earlier than one-phase treatment. So I think paradigm should shift for this two-phase treatment. I think we should do a lot more two-phase treatment than before. Actually, I'm not really the expert for this airway issue. So if you have more interest in airway, please don't miss this lecture. This is scheduled, I think, today. You will hear about a good explanation about the airway from ENT doctor and orthodontist. So again, if we see our patient's profile straight, I explained if there is no orthopedic problem, we usually recommend it in adult stage treatment. But even here, we can consider early treatment if patient has any functional or health risk. For example, if patient has severe rotation, which can cause occlusal interferences, we need early dental correction. And if we see early traumatic occlusion, like this gingival dehiscence, we need early treatment. And if we do early first molar distalization, we need early treatment. And if we see potential canine infection, we really need early canine eruption guidance, usually by upper expansion. So today I explained the general overview for class 1 and class 2 and class 3, and I emphasized facial evaluation. And also, I emphasized patient's psychosocial aspect. If we take care of all these together, then that will be holistic care for our children. Thank you very much for your attention, and thank you for your participation. And I hope all of you be safe from this COVID-19, and see you someday in real in Pediatric Dental Society. Thank you very much.
Thank you very much, Kitae Park. Actually, I do see the patient with malocclusion every day, so your lecture is very helpful. Yes, for me to practice. Okay, it's the Q&A session, and I chose some questions from the attendees. From Anna Viro, her question is, how is the cooperation of young patient wearing the face mask and intraoral appliances?
Actually, it's very good, because I explained already because I consider face mask before middle school. I think that's the latest time. The latest time I use face mask is elementary 5 or 4. So usually I think more than 90% I have good compliance. No problem.
Yes, I also had the patient, very young patients with face masks, actually only a 6 or 7 year old. I strongly recommend it more than 14 hours a day. They should wear face mask. And it's a very, yeah, they're cooperative pretty well. Okay, and next question is from Catherine Blaine. Uh, has there been an assessment of how many more children have trauma to their anterior teeth if they have larger overjet and the orthodontic care is done later? So how the larger overjet affect their possibility of the trauma on their anterior teeth?
How? I don't really understand how, but how severe?
Yes, that how many more children have trauma if they have a severe overjet than the normal overjet
Ah,
children?
ah.
Yes.
I think there are a lot of articles about anterior teeth trauma because of increased overjet, but I cannot really say the exact percentile. But if patient has increased overjet, it's a lot more trauma prone. That's what I agree.
Yes, the 2 or 3 times they have more chance possibility to have a
Mm-hmm.
trauma. Yes, they have severe overjet.
Yeah, yeah, yeah.
Okay, and the next question it shows.
I saw, is there a difference in the age intervention between girls and boys? Yeah, that is true because actually for the compliance, it's different girls and boys, and also their growth spurt is different. So if I consider treatment timing, I always think differently for boys and girls. So that is true.
Okay, so other question is from Mariachi Weekly from South Africa. The question is, what is the youngest age you can start? Actually, she has a 2-year-old patient with a very high palate, no breathing problems according to the mom. Tonsils are huge, but no problems with it according to mom. So you can start with a
Mm.
2-year-old patient.
Mm. So for class 3 patient, I start from at age 4.5. I can start by face mask. But for class 2, I usually use functional appliance or a cervical headgear. So I think the age should be at age 8 or 7 in early mixed dentition for class 2. But for class 3, you can start face mask at age 5. But uh, actually, at age 5, face mask, as a pediatric dentist, we can do it. But usually, orthodontists, they don't want to start that early because they have they don't really feel comfortable to start early treatment. So that's the difference between me and other orthodontists because I'm also pediatric dentist.
Okay, next is a question from Susan Walford. What aspects are you looking for on the hand wrist x-ray to show growth spurt? So she asked, what is the alternative signs could she check without using a hand
Uh,
wrist x-ray?
Actually, you can check secondary sexual characteristics for the one-phase treatment, but in really early age, in for two-phase treatment, you don't really need hand wrist X-ray because it's way before growth spurt. But when I see the patient at age 12 or 13, I usually check hand wrist X-ray, but sometimes other people use like a cephalometric X-ray. They check, I forgot the name, the cervical vertebra. They check cervical vertebra. And there are many ways, but I prefer hand wrist X-ray. So it's up to doctors.
Okay, next question is from Eka Shofia. Kitae Park, what's your view on myofunctional appliance like MyoBrace to treat class 2 and 3 in early age patients? Yeah, it's pretty hard issue.
Yeah. Personally, I don't really use those MyoBraces and T4K, something like that. But I use them as a retainer after my phase 1 treatment because I was not really successful to get good compliance, and also I cannot really expect highly for my treatment result. So that's why I don't really use that kind of appliance. But I don't really have a strong objection, but that's just my personal preference. But in Korea, I think there are some problems to get good compliance.
Okay, great.
Because in Korea, children are too busy, so it's very difficult to get good compliance.
Okay, so as for the compliances, it's from the question from the Anna Bureau. So how many hours did the 12-year-old patient have to wear the headgear? How many hours?
I think 12 hours should be enough because I usually ask them wear at home when you sleep and after school. I never ask them to wear at school. So I always emphasize if you wear during sleeping, it will be about 8 hours. Then you add 4 hours while you are at home. So I usually recommend 12 hours, but if it's more than that, you can get better results.
Okay, so we have about 10 minutes or so we can take more questions. Okay, next question is from Sargam Sorti. The question is, do you prefer to correct dental crossbites in primary dentition? Even in primary dentition,
it really
depends.
Really depending on the case. Even if I see anterior crossbite with skeletal characteristics, I have some guidelines. Actually, if patient doesn't have any family history, then I can start only primary dentition face mask. But if patient has strong family history of class 3, I usually wait until only mixed dentition because from my experience, I usually have class 3 again in early mixed dentition, even if I tried primary dentition face mask. So it really depending on the case. If you have very simple 1 or 2 anterior teeth crossbite, it's okay. But it really depending on what kind of anterior crossbite you have. So it's very difficult. You really need or not 100%. It's difficult. It really depending on the case.
Okay. So next question is from Mani Bawaza. Can we treat class 3 malocclusion using face mask even at 12 years of age? 12.
At that time, I really check hand wrist X-ray because if that patient is near growth peak, then I can try face mask. But I always ask my patient, if you are agree, then I can help to use face mask. I don't really push any kind of treatment for that age. So it's up to that patient. If she really wants to try it, then I can help her or him to use it. And also I check her or his growth stage.
Okay, next question is very interesting. It's the question from Ray and Omar. Do you experience patient burnout due
Oh
to the
yeah,
long
yeah, yeah,
treatment
yeah,
span?
yeah, yeah, yeah. That's a good question because when we try two-phase early treatment, one of the most important thing is not to lengthening the treatment. So if I don't really have good result after a year, but I already decide the treatment length before I start any kind of treatment. If I don't have good result, but I will stop. I never lengthening my treatment. Then patient will have really burnout problem.
Okay.
So when I consider early treatment, that aspect is very important. You should have really good compliance. So another thing, I always ask my patient if they really want to fix their teeth, then I can provide any kind of treatment.
Okay. Next question is from Rajesh Baker. Let me check. Oh, it's scroll down automatically. Okay. What about intervention through serial extraction? What's the idea of serial extraction?
Serial extraction, I seldom do it, but sometimes I can do it if there is really crowding problem. If I can see
Exactly.
really severe canine eruption problem or something like that, I can try it. But for serial extraction, you should have some checkpoints because patient should have a good class 1 and not really deep bite case, and patient should have good profile. So there are certain guidelines or checklist before you do serial extraction.
Okay, I do serial extraction pretty often. I'm very convinced that I should extract eventually, right afterwards.
Yes. So I
Okay,
want to say, if you 200% confident, then you can
300% or
300.
400% for full premolars. Yeah. Okay, let me check. We have 3 minutes left. Okay, so next question is Catherine Blaine. What type of appliance do you use to do the orthopedic part of the phase 1 treatment? Orthopedic appliances for phase 1 treatment.
For class 2?
Phase 1, I guess. So?
I often use cervical headgear, but nowadays I use a lot of twin blocks. I like twin blocks, so I use functional appliance or cervical headgear. But in treatment result, I don't think there are big differences. But I usually give them the choice. So, for example, if patient has very poor compliance with headgear, then they can be very good patient for twin block. So I can switch the types of appliance. That's what I usually do.
Okay, great. Next question is pretty practical. It's a question from Ahmad Shadu Zakaria. Hello, Dr. Kitae. Any tips on taking impression for appliance construction among child patients? I found it quite challenging due to their gag reflex and tendency to vomit.
Because we are pediatric dentists, so I don't really think we have big problems. But
exactly.
But yeah, this is true. If he or she has very big problem of gagging, then I can delay her or his treatment. That will be better. I will not push them to start treatment. that's compliance issue. So I don't really, one thing very important in my mind is I never push my patient to accept treatment.
Okay, so probably this is the last question. So actually, it's almost
Yeah,
up.
maybe I can
Yeah.
answer to these questions later. It will take time, but I will do that.
Okay. Okay. Great. Oh, it's question from Manisher Bangar. Can we use chin cap appliance for the poor class 3 cases that you showed after face mask treatment in phase 1?
I never use chin cup appliance. I don't think it's really effective. So, and there are always issues of TMD problems. I don't really use chin cups.
Mm-hmm. Yes, I'm not sure it's really works. Yeah, just for retention after, yes, I do
Yeah.
face mask is sometimes, but yeah, just I'm not so I'm not a big fan of chin cup.
I just saw in terms of outcomes, what percent of success you achieved. I would say, I think it's pretty successful, maybe more than 90%, because I select good cases and I select only good compliance patients.
Okay, this is a question from Ray and Norman. How long you keep retention appliances?
Retention.
How long should they
Uh,
keep the retainer?
you know, for orthodontic treatment results, they every orthodontist use retainers very long time. For example, if you give them poly retainer, first 6 months use full time, and afterwards nighttime, and after a year, maybe every other night, something like that. But after phase 1, I use any kind of retainer just for a year, because I should try phase 2 treatment later. So if retention is too long, it's not very good for phase 2 treatment.
Okay. So next question is Rita Pander. Regarding cephalometry analysis, is it reliable in pediatric age group since the mandible is still growing?
Yeah, it's reliable. It's
Yes,
reliable.
it's reliable.
That, but
Right.
you don't really depending on cephalometrics 100%. But I always emphasize facial evaluation is first,
Mm-hmm.
because cephalometrics is about the skeleton. You don't really see somebody's skeleton. You just see somebody's face.
Mm-hmm. Okay. If we speed up, so actually we can cover almost all the questions. So next question is the Jaikaran cow. How can we control the amount of force provided in face mask therapy? And for how much time period its uses is recommended? How long should they keep, how long should they weigh, and how much the force recommended?
Face mask is also maybe 12 hours, and force is always 1 pound. That's what I use. But for primary dentition, I use 3/4 pounds for the force, and I usually recommend 12 hours wearing.
Okay. The next question is a Golgi Sabbath. Question is, I have a patient with severe class 2 and I advised the parent to visit an orthodontist. But her mom had a severe class 2 as well, and she told me she's fine with it and does not find it necessary. How could I elaborate and explain for mom what it is necessary to treat?
It's up to them. If they feel okay,
Totally up
we
to
don't
them.
really ask them to have any kind of treatment. It's really up to them. But if that patient, if the child is in maybe later elementary school, she will realize if she really likes her face, or if she really wants to fix her face. It will be up to her, not up to the parent.
Okay, so next question is from Seung-Hwan Ong. He said that he heard that it's recommended to use face mask about maximum 1 year or so. So if you need really use the second face mask, do you recommend the second use of face mask?
I seldom use second face mask. Sometimes I use it, but I rarely use second stage face mask. And when I use face mask, I never lengthen my treatment period more than a year. Usually, you can achieve good result in 9 months, but I maintain 1 year treatment length because of retention. So if you use face mask for primary dentition, you achieve very good result within 6 months. But I maintain 1 year for good retention. But more than 1 year, you don't really need it.
Okay, the next question is Fahima Ismail. I have a 3-year-old with unerupted 53, the baby tooth, and eruption cyst in that area. What age would you recommend treatment for 30-year-olds are not very cooperative?
You mean the
Eruption
cyst
cyst
problem?
with, yes,
Eruption cyst problem?
and the baby canine tooth.
If it's really important for that erupting canine, I usually ask her to have surgery in oral maxillofacial surgery, even under general anesthesia, because I don't do general anesthesia or sedation. But maybe you can answer for this question, Dr. Kim.
Wait and see.
Wait and see.
Wait and see.
Okay.
Yes.
Okay.
Only 3-year-old. Yeah, patients. Wait and see.
Okay.
Okay. It's yes. Still, we have some questions from the attendees, but it's time. We need to wrap up. So
Okay.
if you leave your question on the Huba application, on the right side, there is a Q&A session for this session, the lecture. So Professor Kitae Park will answer the question you left afterwards. So you have actually full access to reach all video lectures recorded or real time as well. And you can ask the question and you can get the answers from the speakers afterwards during the event. So yes, thank you for the great lectures and the wonderful presentation, Professor Kitae Park. And hopefully you can enjoy every moment in IAPD20 virtual. So let me announce one more thing. So I am the chair of Public Relations Committee of IAPD. So we are building the IAPD networks, young pediatric dentist networking. So if you are the young pediatric dentist with less than 7-year experiences and you're very interested in pediatric dentistry networking, so just please contact me. Just feel free to contact me at my email address and join the IAPD network team, which is really great. Okay, let's call it the session.
Okay, always be healthy.
Keep safe and healthy, and enjoy the rest of the event, IAPD20 virtual. Thank you. Bye-bye.
Thank you very much, Dr. Kim.
Thank you.